from any cause. So if we look at the mechanisms of AKI in patients with cirrhosis, the etiology is multifactorial. So this image shows the different etiologies of AKI in patients with cirrhosis, uh, out of which predominantly there are three causes, which are acute tubular necrosis, pre-renal azotemia, and HRS1. So acute tubular necrosis constitutes 15 to 60%, pre-renal cause of AKI 15 to 45%, HRS1 which is 10 to 40%. Other causes are abdominal compartment syndrome, or it can be an underlying CKD, or the patient may have glomerulonephritis or interstitial nephritis. So if we take the three important causes like pre-renal, acute tubular necrosis and HRS, there are some underlying precipitating or etiological factors for these causes of AKI. For pre-renal AKI, it may be excessive use of lactulose, which can lead to GI losses, or excessive use of diuretics, which can lead to intravascular volume depletion or GI bleeding or large volume paracentesis, or sometimes use of NSAIDs can also cause pre-renal AKI. This is because generally in patients with cirrhosis, the mean arterial pressure is low. To maintain the blood supply to kidney, body will release prostaglandins to maintain that blood supply. So if we give NSAIDs, this can lead to the decreased prostaglandins and can lead to afferent vasoconstriction of the kidneys, afferent arterial vasoconstriction. So this can present like pre-renal type of AKI. Coming to acute tubular necrosis, this is generally due to drugs like aminoglycosides or any other antibiotics, or contrast injury. It can be due to shock, sepsis, or it can be by bile salts, or severe GI bleeding, which can lead to hypotension and can also cause acute tubular necrosis. HRS can be precipitated by spontaneous bacterial peritonitis or severe GI bleed. Coming to different mechanisms of the pathophysiology of AKI in these patients. First, if we see the HRS, what happens is in a patient with cirrhosis, because of the hepatic damage, there is increased intrahepatic pressure. Increased intrahepatic pressure will lead to increased portal vein pressure, and because of that, there is increased shear stress on the walls of the portal vein, and that leads to release of vasodilators, mainly nitric oxide. This nitric oxide, it will cause the splanchnic vasodilation. Splanchnic in the sense the blood surrounding the arterial supply surrounding the abdominal viscera is called as splanchnic circulation. There is predominant vasodilation, so it will lead to pooling of the blood in the splanchnic circulation, and this will lead to decreased vascular resistance, and blood pressure will fall down. As the blood pools in the splanchnic vasodilation, there is not much of the blood left over in the other part of the circulation. So there will be decreased effective circulatory volume. Absolute volume may be fine, but effective circulating volume will be less. So the body will sense that there is less blood volume. So it will lead to activation of sympathetic nervous system and renin-angiotensin system, and that will lead to production of noradrenaline and angiotensin 2, and this will cause the intense renal vasoconstriction. And one more factor is also important in these patients is the inflammation part. These patients will have translocation of bacteria from the intestinal wall that will lead to inflammation. Inflammation will also cause a release of vasodilators. So these are the two important factors in the pathophysiology of the hepatorenal syndrome. There are so many other pathophysiological causes for AKI in patients with cirrhosis, like abdominal compartment syndrome, where because of the increased intra-abdominal pressure, there will be increased pressure on the renal vein. As the renal venous pressure increases, this will lead to decreased glomerular filtration rate. The other one is the cardiac related. Normally, as you all know, there is increased cardiac output in patients with cirrhosis. Gradually, as the cirrhosis worsens or the disease worsens, there is cirrhotic cardiomyopathy where there is decrease in the cardiac output. So ultimately, that will lead to decreased blood supply to the kidneys, and it will also lead to uh, decreased GFR. So this is called as hepatocardiorenal syndrome. And the other cause is the hepatorenal reflex. This is a newer entity where whenever there is increase in sinusoidal pressure in the liver will release the adenosine and serotonin. This will activate the sympathetic nervous system from the liver to the brain. The signal will go to the brain, and from brain, the sympathetic nervous system will get activated of the kidneys. So, and that will lead to renal vasoconstriction. This is called as hepatorenal reflex. And there can be acute tubular injury in these patients because of the inflammation or infection or cholestasis, where there is increased cytokine levels and endotoxins or bile acids. This is called as cholemic nephropathy. All these things can lead to toxic AKI. So this is a microcomputed tomography image of kidney cortex of a rat, in which has artificially induced cirrhosis, where we can see this is a controlled rat. The the density of the blood vessels in the cortex is high when compared to cirrhotic rat kidney cortex, where we can see the density is less. So this is what generally happens inside the kidney in patients with HRS. So initially this is reversible. So there is only decreased blood supply, but if the hypoperfusion is prolonged, that will lead to ischemia, endothelial injury, and it can lead to irreversible defects. And one more important point in relation to HRS is whenever there is decreased intravascular volume due to any other cause in the body, normally cortical blood flow is maintained, but medullary blood flow is decreased. But in patients with HRS, it is opposite. The cortical blood flow decreases, but medullary blood flow is maintained. So all this sodium retention and all takes place in the medulla. So because the blood flow is maintained there and the intravascular volume is less and the body senses that there is less intravascular volume, it will lead to avid sodium retention in these patients, which can be useful for diagnosing these patients. So this image shows the temporal evolution of hepatorenal syndrome. Initially, in the initial stages of HRS, the kidney histology looks fine and urine doesn't show any gross abnormalities. These are only the blunt casts which can be seen in the urine, and the bilirubin level will be not very high, and the response to vasoconstrictors is high. As the disease worsens, the bilirubin level increases and the kidney injury also increases. As we can see, the histology, the kidney gets more damage. The tubular injury sets in, and we can see the granular, muddy brown granular casts in the urine. These are the bilirubin casts. So, and these appear whenever the bilirubin level is very high. So, in this stage, the bilirubin level will be high, the kidney damage will be seen histologically, and the response to vasoconstrictors is less. Coming to kidney function estimation in patients with cirrhosis. This is an important slide. Uh, Creatinine is normally used everywhere to measure the kidney function, but it is a grossly inadequate marker in patients with liver disease because it can be affected by many factors. First and the most important is the liver disease. Normally, creatinine is produced in the liver and then it is taken up by muscle. From in muscle, the creatinine is formed, which is secreted into the blood. If there is liver disease, excuse me, there is less creatinine generation, and as such, in patients with cirrhosis, there is muscle wasting, so there is less creatinine generation. And these patients are also on low protein diet and less meat intake. That will also lead to less creatinine generation. And because of the ascites and the third spacing, there is increased volume of distribution of creatinine. So as such, there is artificial dilution of creatinine in the blood. And bilirubin, which is high in these patients, can interfere with the creatinine estimation with the alkaline picrate method, which is a Jaffe assay, which we do in our hospital, which is a modified Jaffe assay we do. Here in our hospital, I have confirmed with the biochemist. The interference is present if the bilirubin level is generally more than 30, but they have a correction factor to take care of it. So because of all these factors, the creatinine, even if it is normal in the range of 1 to 1.2 with respect to any other patient, it may suggest a GFR of less than 60 ml in these patients. So creatinine overestimates kidney function in patients with cirrhosis. So with respect to urea also, As urea is produced in the liver, if the patient has liver disease, there is decreased synthesis of urea, and it can also be affected by protein intake and GI bleeds, which can lead to increased urea levels in these patients. So does it mean we should not use creatinine? No, because creatinine is the only practical biomarker for the kidney function estimation which we can use. There are uh, uh, other markers also like cystatin C, but their availability is not very wide and they are costly, and there are not many studies in relation to HRS. So, the baseline creatinine is very important to understand the current status of kidney function in these patients. So, ideally, if the kidney function is normal in a patient with cirrhosis, the creatinine level is usually around zero point 0.5 to zero point 0.6. So, even a creatinine of 1 milligram will be significant in these patients. In a previous definition of HRS of 1996 and 2007 criteria, they have used a cutoff of creatinine more than 1.5. But this is inappropriate because this value usually means a GFR of around 30 ml, and it will not tell about what has happened to creatinine in the previous days, whether it has increased from 0.6 to 1.5 or it has increased from 0.1 to 1.5. So this will prevent us in interfering in the early stages and managing these patients. Coming to newer AKI definition of International Club of Ascites, this was published in 2015. According to this International Club of Ascites AKI definition, any baseline creatinine is any creatinine which is obtained in the previous month when available, and if more than one value is present, whichever value which is closest to the admission hospital admission should be used. And coming to definition of AKI, increase in creatinine more than or equal to 0.3 milligram, which occurs within 2 days, or if an increase in creatinine is more than 50% from the baseline, which might have occurred within last 7 days. And based on this, they have staged the AKI, stage 1, 2, and 3. Stage 1 is if the creatinine increases more than or equal to 0.3 milligram, or if the creatinine increases 1.5 to 2 times the baseline.
Here, sorry to disturb. One small character. This is HRS AKI or AKI in general? HRS AKI specifically,
This
right?
is HRS AKI
Okay.
classification.
Thank you.
Yes. So coming to stage 2 AKI is if the creatinine increases 2 to 3 fold from the baseline. Stage 3 is if the creatinine increases more than 3 fold from the baseline, or if the creatinine is more than 4, or if the patient has initiation of renal replacement therapy. Further, the stage 1 is divided into 1A and 1B. This is because 1A is if the creatinine is less than 1.5 and 1B is more than or equal to 1.5, because less than studies have shown that creatinine less than 1.5 has the mortality equal to the patients who doesn't have AKI. If we manage it early and the creatinine settles from below 1.5 to baseline level, the mortality is equal to patients who doesn't have AKI. But if the creatinine is more than or equal to 1.5, mortality exponentially increases when compared to patients who doesn't have AKI. So coming to newer definition, initially the HRS1 is now called HRS AKI, HRS2 is now called HRS non-AKI. HRS1 AKI, HRS1 AKI I'll be elaborating in detail. Coming to HRS2, HRS non-AKI, it is of two types, HRS AKD, acute kidney disease, and HRS CKD. HRS AKD is if the creatinine elevation is present for less than 3 months. The GFR is less than 60 ml, but it is for less than 3 months, and there is no other cause of kidney disease in the patient with cirrhosis with ascites. If the same thing is present for more than 3 months, the GFR of less than 60 ml, it is called HRS CKD. Coming to the comparison of the diagnostic criteria of HRS, this one is the 1996 initial criteria, the second one is the 2007 ICA criteria, and the latest one is the 2015 criteria. So if we see the change, they have removed the absolute value of creatinine. In the 2007, they wanted a creatinine of more than 1.5 and doubling of serum creatinine to more than 2.5 in less than 2 weeks, which is not present in the current criteria. And they've also removed a minor criteria from the 1996 definition of urine sodium and urine volume and urine osmolarity features. but these are important adjunct for our diagnosis. So coming to other important features for the diagnosis of HRS, in a patient with ESLD and ascites, there should be a definition of AKI as previously told, and there should be no improvement in kidney function after 2 days of IV volume expansion with albumin of 1 gram per kg per day and diuretic withdrawal. There should not be shock, there should not be any nephrotoxin exposure, and there should be absence of overt hematuria of less than 50. There should be RBC should not be more than 50, and absence of proteinuria more than 500 should not be there, and there should be normal kidney ultrasound. So I'll be discussing about few of the components of this diagnostic criteria, the uses of which, the pitfalls, and how we can improve our diagnosis capability. Coming to first one, which is the volume status correction. It is a critical component of diagnostic criteria of HRS1. There is a blanket guidance of 1 gram per kg up to 100 gram per day for 24 to 48 hours.
Kishore, sorry, once again. One small query. The previous slide you showed diagnostic criteria was it specifically for type 1?
This is type 1. This is type 1.
Oh. The previous slide, okay, type 1.
Yeah. This one, sir. Okay. So the blanket guidance of 1 gram per kg up to 100 gram per day for 24 to 48 hours. This is not tailored to the volume status of the patient, and there is no mention of any method to assess whether the volume replacement is adequate or not. So this can be done by point of care ultrasound recently, which has come up, and it is used in and out in ICUs, and all the physicians, nephrologists, and ICU personnel are frequently using in the Western world, and it has dramatically changed the management. So focus can be used to assess the IVC diameter and collapsibility to decide on volume status. To show the evidence for this, this is a study which is published in 2019 in American Journal of Nephrology. Here they have taken this. The name of the study is Point of Care Echocardiography Unveils Misclassification of AKI as Hepatorenal Syndrome. What they have taken is a patient with cirrhosis with AKI who had, based on the criteria of HRS1, diagnosed as HRS1, then their volume was assessed by point of care ultrasound, and in them they have seen the diameter of IVC and collapsibility index. So first, if the diameter of IVC is less than 1.3 centimeter and if the collapsibility is more than 40%, they have categorized as fluid depletion. And if it is less than 1.3 and collapsibility is less than 40%, they have categorized as intra-abdominal hypertension, along with other additional feature of ultrasound, which is called as nipping sign, where we can see the IVC is suddenly narrowed here when compared to the IVC which is present below because of the ascites and intra-abdominal hypertension. If the IVC diameter is between 1.3 to 2 centimeter, they have categorized as fluid depleted. And if the diameter is more than 2 centimeter and collapsibility is the normal range of more than 40%, they have categorized as fluid depleted. If it is less than 40%, they have categorized as fluid expanded. So based on this category, they have done an intervention categorization. So if they have found that it is fluid depleted, they gave IV albumin. What they have found is within 2 to 3 days, 40% showed improvement in creatinine, 27% were stable. If they have found there is intra-abdominal hypertension, they have done large volume paracentesis where 50% improvement in the creatinine. And if they were fluid expanded, 91% received diuretics. There, 30% showed decrease in creatinine and 30% remained stable. And if they were fluid repleted, vasoconstrictors were alone given when they showed 37% improvement in creatinine and 40% had stable creatinine. So this study tells us about the importance of volume assessment before going ahead with vasoconstrictors or directly to any patient without inadequate assessment of fluid status. Coming to other study, this is only abstract I could found. This is not yet published. This is a retrospective study as from a single center in the United States where they have used the IV collapsibility index, which is IVC max minus IVC minimum by IVC max into 100%. They have defined as IVC collapsibility of less than 20%. It means that volume is high where diuretics were given. If the collapsibility is more than 40%, they've labeled as not hypervolemic and volume was given. So, in patients who were volume overloaded, of 8 patients, diuretics were given, 5 showed improvement. And based on the IVC criteria, patients who were not hypervolemic, IV albumin was given. So, 3 were showing improvement in the creatinine. So, according to them, 42% of the HRS patients showed improvement in creatinine with volume management. So, this is very important, especially in relation to management of the patients, because this can prevent respiratory complications also if we find volume overload in these patients, and we can prevent unnecessary interventions of or unnecessary drugs. Coming to other pitfalls in the diagnostic criteria, important factors are missing from this diagnostic criteria, like lower normal BP or the sodium level or oliguria. And as I've already told from the 1996 criteria, urinary sodium values are missing, which are important for the diagnosis of these patients. Other important feature of this, other important diagnostic criteria is the normal ultrasound of the kidney. But this may not be always seen in our patients because of the ascites. Increased echogenicity can be found in the kidney. Normally, increased echogenicity suggests there is something inside a kidney, a problem with the parenchyma of the kidney. But this may not be always true. So, in a patient with HRS, we can find increased echogenicity. So, we need to take the whole picture, urine evaluation, everything into consideration before acting upon this finding. Coming to urine analysis, according to the criteria, we need to exclude HRS if there are more than 50 RBCs per high power field and proteinuria more than 500 milligram per day. This doesn't consider the glomerular diseases which can be seen in these patients like IgA nephropathy or NPGM. These glomerular diseases can cause more than 50 RBCs and more than 500 milligram per day proteinuria. So if we don't have a baseline urine analysis of these patients, so we can miss a HRS1 diagnosis in these patients. So this we need to keep in mind. And sometimes traumatic hematuria due to Foley's catheter can also cause more than 50 RBCs. And as according to the criteria, more than 50 and more than 500 are the cutoff. But so traumatic hematuria sometimes can also cause more than 50 RBCs per HPF in the urine. And some causes of AKI with etiology inside the kidney, like acute interstitial nephritis or glomerulonephritis, can have RBCs of 10 to 50, in which we cannot diagnose HRS1 because according to criteria, if it is less than 50 and less than 500 and all other features of diagnostic criteria are fulfilled, we can diagnose them as HRS1. But these patients with acute interstitial nephritis due to drugs can present in a similar way. So this we need to keep in mind. And RBC morphology in the urine is also important because dysmorphic RBCs are of glomerular origin usually. So this is very important pointer for helping us to categorize these patients. Other important factor is the leukocytes in the urine, which is not mentioned in the criteria. Normally, leukocytes in the urine generally suggest urinary infection if the culture is positive, and this UTI can be a trigger of HRS, or sometimes WBCs in the urine with WBC cast can be due to acute interstitial nephritis. So, if this is the case, if the culture is negative and WBCs are there in the urine, and there is history of drug exposure, we need to consider acute interstitial nephritis rather than HRS1. Coming to other urine analysis finding, the urinary sodium. Here we use generally urinary sodium and fractional excretion of sodium for the diagnosis. Fractional excretion of sodium, to put it simply, this tells about how much fraction of sodium which is excreted in the urine out of the out of the filtered amount at the glomerulus level. So this is done by this formula. And if the fractional excretion of sodium is less than 1% and urine sodium is less than 20, these are the two universal findings in patients with HRS. So why is this? Because I have already told there is decreased mean arterial pressure, there is increased angiotensin 2 and increased noradrenaline, and there are other hormonal factors which causes avid sodium retention in the kidney. So kidney tries to retain more amount of sodium. So the urine shows less sodium and the fractional excretion is less than 1%. So if we find the fractional excretion of more than 2% and urine sodium of more than 40, this is inconsistent with HRS. This we can say. This we can say. But if the sodium fractional excretion is less than 1%, does it tell about HRS diagnosis always? No. So this study, which was done in patients who are going to be going for liver transplantation, a prior kidney biopsy was done because the GFR was less than 40. Here we can see HRS, almost all patients had fractional excretion of sodium below 1, but even ATN, MPGN, uh, kidney fibrosis, all these had and fractional excretion of sodium less than 1. So fractional excretion of less than 1 doesn't always tell that it is the HRS diagnosis. Instead, if it is more than 1, we can rule out the diagnosis of HRS. The sensitivity of fractional excretion of less than 1% is 100% sensitive, but it is only 14% specific. Coming to a uh, newer laboratory, excuse me, liver laboratory criteria, which is recently coming up. There are a few studies on this, which is a fractional excretion of urea. In a study which was published in 2018, if they have taken a cutoff of 33.1 for fractional excretion of urea for a diagnosis of ATN versus non-ATN, with ratio of fractional excretion of urea more than or equal to 33.1 suggesting ATN, the sensitivity was 100%, but specificity was 85%. For HRS versus non-HRS, the cutoff was 28.16 with sensitivity of 75 and 83. For pre-renal azotemia versus HRS, the cutoff was 21.35 with sensitivity of 91 and specificity of 61, with 21 less than 21.35 fractional excretion of urea suggesting HRS and more than 21.35 suggesting pre-renal azotemia. So this also we can use in our laboratory evaluation for identifying HRS1 patients. Coming to the important differential diagnosis of HRS1, that is the acute tubular necrosis. The causes are generally NSAIDs, drug-induced or radio contrast exposure, or septic shock or severe hypotension. To identify the differences between HRS1 and acute tubular necrosis, we need to see the rise in the creatinine. Here in ATN, there is a rapid rise in creatinine, whereas in HRS, usually it is a gradual rise in creatinine. And prolonged HR is due to persistent vasoconstriction that can also lead to ATN. So this we need to keep in mind, because HRS may not be totally reversed, because if the underlying kidney damage is severe due to ATN or because of the prolonged HRS, this HRS can be converted to ATN. And fractional excretion of sodium more than 2% generally supports ATN. And but patients with ATN and cirrhosis can have fractional excretion of sodium below 1, as I've already mentioned in the previous slides. And granular casts in the urine usually support the diagnosis of ATN. Coming to algorithm of management of these patients, according to the 2015 guidelines, the diagnostic guidelines for HRS1, first, if the patient has stage 1 AKI, as I've already mentioned, where the creatinine increase is more than or equal to 0.3 in the last 48 hours or 1.5 to 2 times in the last 7 days. And this can be divided into stage 1A and 1B. If the creatinine is less than 1.5, it is stage 1A, more than or equal to 1.5, 1B. Here, we need to remove all the risk factors for AKI, like withdrawal of nephrotoxic drugs, vasodilators, or beta blockers, or NSAIDs.
Yeah, Govinda sir. Before Kishore joins, one small doubt. I mean, maybe either you or the Govinda or Dheeraj can clarify, sir. Just tell me this. Does diagnosis of HRS require presence of ascites? I mean, all the mechanisms you told, shear stress, nitric oxide, renal angiotensin, hyperdynamic circulation. So, is it like in the absence of ascites also you can have HRS, or at least type 1 HRS? Does it mandatory ascites?
No, ascites is part of CLD, so it can be there, but it's not a mandatory for having. But generally, they will be having ascites because of this other mechanisms.
When a patient comes with creatinine elevated, is going up, and in an ascites patient, we're always thinking more of HRS. While if the patient is
Correct.
dry, clinically dry, even that patient could still be a pure HRS, but and a non, or in those patients, you're more
It
likely
may
to
be,
have
it may be,
secondary causes.
yeah, it may be other cause of pre-renal azotemia. The patient is not having ascites,
So,
and the patient is stable otherwise, chronic liver disease. We have to think of other causes of pre-renal, which is mentioned in the other causes. Yeah, Dr. Kishore?
so in the absence of ascites, it is very unlikely that it will be HRS. Although in like severe alcoholic hepatitis, we can get HRS without ascites, but in mostly if ascites is not there, HRS is unlikely.
But Dheeraj, the mechanisms he was mentioning, उसमें ascites का क्या role है? Higher shear stress, increased nitric oxide, activation of renin-angiotensin mechanism. I mean, of course, they cause
Sir,
more sodium
absolutely.
fluid
They
retention.
all have they all have role in ascites only because
Similar,
ultimately they
yeah,
will lead to
exactly.
ascites
Okay.
only.
Mechanisms are same basically in
So
ascites and
without causing ascites, they cannot affect kidney. Matlab, if the mechanism is so profound that it is leading to renal vasoconstriction and decreasing the effective volume that is going to the kidney, then there has to be ascites by the same
Got
mechanisms.
it, got it, got it. Okay. Yeah, Kishore. I think he's back. Kishore is back.
So if there is stage 1 AKI, so we need to remove the risk factors. And if the patient has hypovolemia, we need to expand the volume. And we need to observe. If the creatinine comes down, then it is fine. If it is stable, we need to decide on a case by case basis. We need to see other factors, what is going on. And if the creatinine worsens, then we need to give them volume with albumin of 1 gram per kg per day for 2 days with withdrawal of diuretics if it was not done. And if there is response, then it is fine. If there is no, and if there are other criteria for HRS1 which are meeting, then we need to confirm the diagnosis of HRS1, and then vasoconstrictors and albumin to be continued, and vasoconstrictors to be added and albumin to be continued. If they are not meeting the criteria of HRS, we need to look for the other causes of AKI which I have mentioned. I'll be elaborating about this treatment management. The first one is the target of treatment. This image shows the mean arterial pressure in patients with HRS1 in 37 cohorts. Here we can see the mean map is 74.6 and the median map is 76. So this is the mean map in patients with HRS usually. And our target is to change the map 10 to 15 millimeters per mercury above the baseline to around 85 to 90 millimeters of mercury. Why is this? So this depends on the renal auto-regulation. So there is something called renal perfusion pressure, which is mean arterial pressure minus intra-abdominal pressure. So in patients, in normal patients, generally renal blood flow maxes out when the renal perfusion pressure is 65 millimeters of mercury. But in patients with HRS, this curve shifts to right due to sympathetic nervous system activation, and there is a window in the shaded area where vasopressors can act. And the mean arterial pressure, if we increase up to 90, there is a increase in the renal perfusion, renal blood flow in proportion to the increase in the mean arterial pressure. This is also shown by a pooled analysis of 501 patients in the 21 studies. There is a strong inverse correlation between the magnitude of rise in mean arterial pressure and absolute decrease in the serum creatinine, and this was irrespective of the vasoconstrictor use. Here on the x-axis we can see 7-day change in the mean arterial pressure. On the y-axis there is 7-day change in the serum creatinine. So if there is increase in the MAP to more than 10-15, we can see there is a decrease in the creatinine. So the magnitude of change of MAP correlates with the magnitude of change of the creatinine. Coming to other important component of the treatment, which is IV albumin. IV albumin is for the volume expansion, basically to increase the intravascular volume. Also, IV albumin is told to have anti-inflammatory properties, and the recommended dose according to the guidelines is 1 gram per kg up to 100 grams on day 1 and up to 20 to 40 grams from day 2 onwards. This is varied. In some guidelines for 2 days they ask 1 gram per kg, for 2 days, and after that we can give 20 to 40 grams. But in a recent large study which was published in NEJM, this was the guideline which they have, this was the protocol which they have used. But can we give only terlipressin without albumin? No, the effect is very less. So this is a 2002 study where they have compared terlipressin plus albumin versus terlipressin alone. Here we can see the response was 77% in if albumin was added, compared to 25% alone if only terlipressin was given. So the drop in creatinine, if we can see here, if the albumin is given, it is clearly more when compared to only terlipressin. Coming to vasoconstrictor therapy, normally we use terlipressin, noradrenaline, and midodrine plus octreotide. Midodrine is an alpha-1 adrenal receptor agonist which acts as an oral vasoconstrictor. Dose is usually 5 to 15 milligrams every 8 hourly, and it can be titrated. Octreotide is a somatostatin analog. It decreases the production of splanchnic vasodilatory substances, and dose is 100 to 200 micrograms subcutaneously every 8 hours, or it can be given as an IV infusion. So ultimately, as I've already previously mentioned, the target is to change the mean arterial pressure to more than 10 to 15 millimeters of mercury of the baseline. And the response is defined as change in serum creatinine to less than 1.5, a decrease of serum creatinine to less than 1.5 milligram per deciliter. This is the old definition of response. But in the newer guidelines after 2015, complete response is return to within 0.3 milligram per deciliter of the baseline creatinine for a maximum of 14 days, up to which we can give the vasoconstrictor therapy. Terlipressin, it is a synthetic vasopressin analog. It is a prodrug. It is metabolized by exopeptidases to release the lysine vasopressin. And this lysine vasopressin has more affinity for V1 receptors when compared to V2 receptors which are present in the kidney. V1 receptors are present in the vascular smooth muscle, and the affinity is 6 times more for V1 receptors. And compared to only vasopressin, lysine vasopressin has an advantage of more affinity for V1 receptors and longer duration of action when compared to only vasopressin. Here the mechanism is, it will cause the splanchnic vasoconstriction and it will shunt the blood to systemic circulation, and this will lead to reduced sympathetic nervous system and RAS activation, and it will improve the kidney function. So the dosage is 0.5 to 1 milligram every 4 to 6 hours, and it can be increased up to 2 milligram per every 6 hours if the reduction in creatinine is less than 25%, or we can give by continuous infusion 2 milligram per day at start and adjusted according to the response every 48 hours up to 12 milligram per day. The side effects are important, which can be seen in 45% of the patient. They are commonly abdominal pain, diarrhea, nausea, and ischemic complications. So coming to comparison of terlipressin with midodrine and noradrenaline. Midodrine and octreotide, it is proven that terlipressin is more effective when compared to midodrine and octreotide. Here we can see in this study the response, the reversal rates of HRS1 is 70% with terlipressin, whereas it was only 29% with midodrine with octreotide. And if we compare the terlipressin with noradrenaline, generally the response is almost equal between these two. Here these are the studies with the number of patients. Here we can see the terlipressin IV bolus dose was compared to noradrenaline infusion. Noradrenaline we start at 0.5 milligram per hour and up to 3 milligram per hour we can give. This needs an ICU stay and central line, whereas terlipressin can be given in wards and it can be given through peripheral line. That we need to keep in mind. But the response rates are almost equal when compared to terlipressin. But the number of studies are less in comparison to terlipressin with the noradrenaline. And there is one more study where terlipressin infusion was compared with noradrenaline, but the response here was far high compared to noradrenaline, 40% versus 17%. Coming to discussion about terlipressin, after a recent trial which was published in NEJM in 2021, which was called as CONFIRM study, which was terlipressin plus albumin for the treatment of hepatorenal syndrome. As we all know, in the United States, only midodrine plus octreotide is used for HRS1 because terlipressin is not approved there, and they also use noradrenaline. This was a pharma-driven trial to get the approval of the terlipressin with the guidance of FDA, and FDA wanted a specific endpoint, primary endpoint of primary HRS reversal, which was defined as serum creatinine less than 1.5 of two values and without requiring renal replacement therapy after the completion of the treatment. So what they did was they did the study in US and Canada with 2:1 randomization. Mean creatinine was 3.5, mean bilirubin was 13.1, and there was albumin co-administration. With terlipressin, there was a more HRS reversal, 32% when compared to 17%, and the RRT need was also lower. And but at the initial stages of the study, more amount of patients in the terlipressin were listed for the liver transplant. But at the end of the study, they can see only 23% in the terlipressin group would be transplanted, whereas 29% in the placebo were transplanted. Mortality was almost similar. But the most important alarming point was there is increased risk of respiratory failure in patients with terlipressin. The risk was 14% in terlipressin group compared to 5% in the placebo group. So conclusion was terlipressin is effective for type 1 HRS. There is no doubt in that, but there are associated more serious side effects, including respiratory failure. Going into this study, in which group of patients terlipressin was effective? Basically, in alcoholic hepatitis patients, it was effective. But if we stratify the patients based on the creatinine, as the creatinine level increases, the effect of terlipressin decreases. If the creatinine is less than 3, the effect was more when compared to terlipressin. If the creatinine is more than 5, the effect was not that good. And this is the side effect profile of these patients. Here we can see overall the side effects were any adverse events were similar between the two groups. But other side effects of importance to us, because recently we had a patient with cirrhosis on terlipressin with atrial fibrillation. It was seen in 1% of the patient in the terlipressin, but it was seen in three patients in placebo. There can be more abdominal pain, and there is also increased risk of respiratory disorders in these patients. And respiratory failure was seen in here. This image shows the respiratory death related to respiratory failure when compared to placebo in terlipressin patients. Here we can see within 90 days, 22 patients in the terlipressin group died due to respiratory failure, whereas in placebo only 2 patients expired. And whatever all the events, almost everything, or more than 80-90% happened within 14 days. That is the treatment duration of the study. For 14 days only they gave terlipressin. So all the events of respiratory failure deaths happened within 14 days of the initiation of the drug. So based on this, FDA, they have acknowledged that it is effective, but we cannot approve because of the safety issues. And coming to the baseline effect of terlipressin with respect to the baseline creatinine, if the creatinine is more than 5 milligram per deciliter, we can see that the survival is less in patients who were given terlipressin. If the creatinine is more than or equal to 5, the survival was only 30% at the 90 days, whereas who were given placebo, the survival was 50%. The baseline creatinine was less than 5, the survival was almost equal. So this is an important point which we need to keep in mind while treating our patients.
Kishore, sorry to say, one small query. I mean, this trial, the placebo meaning they didn't, the other HRS didn't receive any treatment, or were they getting
only albumin? Only albumin with placebo.
Okay. Okay.
So why respiratory failure can happen in patients with terlipressin? So this is based on a review article which was published after this study. What they have proposed is terlipressin. It increases the alveolar microvascular permeability, which will lead to edema. It will cause pulmonary vasodilation, pulmonary arterial vasodilation, and pulmonary venoconstriction. So this can lead to increased respiratory failure, and there is also other exacerbating factors like volume expansion with albumin, which we need to keep in mind. And whereas with norepinephrine, it will cause pulmonary vasoconstriction and it will cause stimulation of salt and water absorption in the alveoli, and it is also a mild inotrope, weak inotrope. So this will decrease the respiratory failure when compared to decrease the alveolar edema when compared to terlipressin. So this is what they might have. This is what might have happened, but it is not proven. And most important thing here in this study was, even before randomization, albumin was almost normal in both the groups, 3.7 and 3.8, and approximately they have given total mean albumin was given was 330 grams of albumin was given in two groups. So what there is another school of thought is that with albumin, that high albumin level and terlipressin, that may lead to more complications in the lungs. So coming to terlipressin versus noradrenal, this is a meta-analysis which shows that the effect is almost similar between both the drugs. So whenever we use terlipressin, there should be careful attention to respiratory distress. Pulse oximetry monitoring is required compulsory, and frequent chest radiographs are required, and point of care ultrasound monitoring of volume status and lung congestion is required, and discontinue terlipressin if respiratory complications arise. So coming to the final algorithm of management based on everything which I have told. First, whenever there is abnormal creatinine in a patient, we need to look for the history for any precipitating factors of renal, AKI, or acute tubular injury or fibrosis. Do laboratory analysis, do the imaging data, and look for the IVC and remove the offenders. And initially, you give volume expansion with IV albumin, or based on if the patient has blood loss, we can give blood, or if the patient has pre-renal failure due to diuretics or GI losses, we can give crystalloids. If the creatinine is decreasing, monitor, no further action. If the creatinine is increasing and it is not responsive to volume, then we need to take into we need to use the other features, like if there are no RBCs and the proteinuria is less, the sodium is less in the urine, there are no sediments, no confounders, echo is normal and ultrasound is normal, then we can diagnose HRS1. And if there are more RBCs, WBC CAS, protein in the urine, and if the sodium is more than 30, and if there is hydronephrosis or any other factor in relation to kidney, like whether the diagnosis can be ATN or AIN or ATM, then we need to remove the HRS diagnosis. After we made this distinction, if we don't have a proper evidence where it is not fitting into definite HRS and that's not fitting into definite non-HRS, we need to look into mean arterial pressure, the serum sodium, and the fractional excretion of urea also we can use, and then we can label as probable HRS, and we can start the vasoconstrictor therapy with albumin. In the initial stages, the further treatment here can be tailored to each hospital, because this article is from US. They have used midodrine plus octreotide. Here, based on our experience and our comfort and cost effectiveness, we can use noradrenaline or terlipressin to basically target mean arterial pressure or rise of 15 millimeters of mercury. And if the response is not seen in 3 to 4 days, we can stop the treatment. Coming to take-home points, any increase in creatinine, whether it is small, is significant in patients with cirrhosis because it can affect the survival. And multifactorial etiology of AKI in cirrhosis needs to be considered and ruled out before directly diagnosing HRS. Point of care ultrasound helps in diagnosis and avoiding fluid overload. Terlipressin definitely works, but not in all patients, especially with advanced renal failure. And respiratory complications ought to be monitored and addressed promptly while on treatment with terlipressin. Thank you.
Thank you, Dr. Kishore. It was very informative, going into the in-depth pathophysiology and different mechanisms of rise the creatinine and how important the other parameters are in monitoring as well as in the management. You have highlighted the role of creatinine as well as a fractional excretion of urea and the importance of IVC examination. I think this is a very good point, because I think on the first hour of admission into an ICU with the patient having renal problems, it's better to do IVC study. Am I right, Kishore?
Yes, sir. Actually, Now,
Agree.
there are so many studies are coming out based on this initial volume assessments, based on point of care ultrasound. Actually, we need our physicians and everyone need a small training because it is not very difficult to do. So we can avoid so many complications in our patients whenever radiologists are not around also, because it will help us in immediate diagnosis and management and stratifying, because sometimes ultrasound may get delayed and we may delay the treatment or give inappropriate treatment in these patients. A small
And it's
session of
not difficult to do a bedside
yeah,
IVC by the ICU physicians.
yeah. But I
These
want
are
all the physicians to be trained because it is only 1 or 2 hour course. So with the radiologist, it will be very easy to manage.
And one more thing about this Fe urea,
Yes, sir.
is it easy to perform and can we have it in our lab in our
Yes, sir.
place?
We are doing already, sir. I am already
We are
advising
doing.
to our patients.
Yeah, Dr. Fani?
Sure. Yeah. Yeah. Kishore.
Sir.
Govind, you're saying something, man.
Yeah. Hi, Kishore. It was very nice. They were awesome. I think you took efforts to make them.
Yes, sir. It took 1 week.
You predict for patients who are having raised creatinine, whether they will go into HRS 1 or 2. Are there any definite predictors which you could come across your
Uh,
HRS 1 or 2?
Whether the patient, no sir, it is not based on the predictors, it is only the time frame which will tell us actually, because HRS2 the pathophysiology is also important because vasoconstrictors which we are giving also work in HRS2, but ultimately if you stop the drug they'll come back to their baseline level. So as far as I know, there are no special predictor factors which predict whether patient will go into 1 or 2, but I will recheck and get back to you, sir.
And can we start NORAD by default for all our patients because it's cost effective as well and it has more advantage?
Yes, sir, we can start, sir. Actually, the effect is not much different, but if we take IV infusion of terlipressin with relation to noradrenaline, terlipressin infusion is more effective. And recent studies are also showing that whatever respiratory side effects and whatever complications of ischemic events, they are more with the bolus doses when compared to the infusion doses. If we want to remove the side effects of terlipressin, we can give infusion of terlipressin more commonly rather than boluses. Or
But
else,
we are not albumin doses. We are giving 20 grams,
no, no,
whereas
sir,
it is
infusion of terlipressin
no.
when
I'm talking.
compared to, yeah,
We are
Yeah,
giving
albumin inadequate doses.
20
Yes.
grams.
yeah, yeah,
We are
albumin is
not
inadequate.
20 gram on day one.
Yeah,
So
sir, yes, sir.
maybe we are biased about the increase in albumin because of the low dose which we are giving. Maybe and
That is also.
we give a 100 gram albumin on day one and then
So directly giving 100 gram, I may not advise. We actually want to see the volume status because if we give
Exactly. See
100
the
gram,
volume status in this.
it may patient may go into respiratory failure. So first, I want to you to include in our protocol IVC assessment of any HRS patients. So that is very very important. So then, if volume is less, then we can give albumin happily. If creatinine has gone down, then it is not an issue.
volume only we are talking. Volume. Yes,
Yes,
yes. If it is all, then why will give?
yes, sir.
Kishore, can you hear me?
Sir, I can hear you, sir.
Firstly, really, really wonderful lecture, Kishore. I think among HRS, one of the best lectures I've heard on HRS, making the points very clear. And one thing I understood, it's take home for me in addition is a very active involvement of nephrologist in the management of HRS because there's so many factors involved in patients. Just two queries, Kishore. One is, in these past 3 months itself, we've had 2 cases of pulmonary edema of patients who are on terlipressin, our own patients.
Yes.
So, is there any literature showing definite benefit of NORAD compared to terlipressin, not in terms of effectiveness, but reduced respiratory complications? The other one, the second question is just that as a slide you not covered it briefly. Type 1 versus type 2 in terms of etiopathogenesis, diagnosis, and prognosis and treatment. What are the differences?
Sir, there are definitely studies comparing terlipressin versus noradrenaline. All the previous studies which were done before this confirmed trial, actually this respiratory complication part was not has not come up anytime. And as such, this is after this confirmed study only. And the issue here is definitely there are studies, sir, seeing the respiratory side effects of noradrenaline is definitely lesser when compared to terlipressin. This is also one point in especially in the North America, they want to prefer noradrenaline when compared to terlipressin because but there are so many confounding factors here because the amount of albumin which they have given in this study was way high prior to randomization. Actually, almost all the patients had normal albumin levels before starting terlipressin. So they were pumped with albumin. So they need further study before totally confirming, but they will be cautious. But at present, they are not using terlipressin in the United States. And coming to other query, HRS 1 and 2, sir, the pathophysiology is same, sir, basically. Pathophysiology is same. It is the same vasoconstriction of the kidney, but here there is a chronic recurrent ascites, which is intractable ascites, and the creatinine value when compared to HRS1 generally fluctuates between 1.5 to 2.5 in HRS2 patients. And this creatinine can come down with vasoconstrictor therapy, but why it goes back to again the previous baseline levels of high creatinine if you stop vasoconstrictor therapy? Exactly, I am not sure, sir. I'll look into the literature and get back to you. But it is basically same pathophysiology treatment can be same, but the prognosis is also slightly better in HRS2 patients compared to HRS1.
I mean, HRS2 is better, you're saying.
Yes, yes. Right. The prognosis
But
is
HRS1 reverses, right? Completely, you're saying reverses and comes back to baseline.
yes, yes, yes. If we give treatment, it will come down. If we stop the treatment, it will again to the same creatinine value. And it
That's the
is
reason I asked you whether predictors.
that is
Or,
what the predictors. I'll just look into it.
sir,
I'm not aware.
I think the reversibility of HRS2 is mainly depends on the etiology. Am I right?
Sir, but HRS2 also, one there is no underlying etiologies are not ruled out. One or two other AKI cause of AKI ruled out, right?
Yeah, everything, sir. HRS2 also, it should be no other cause, and in patients with cirrhosis with ascites, same. You should rule out all other causes.
I think now you said nicely about this role of albumin and then noradrenaline and lipids. So I think we have to be very careful. I think from first hour itself, going for an IVC study and giving this albumin in a very judiciously. We should not overpump it or undergive it also.
Yes,
Right.
yes.
Along with, I think as Dr. Govind said, you can straight away give noradrenaline instead of giving the terlipressin because of this impending respiratory complications. So though the response is better with terlipressin, but avoiding this complication is also equally better. Now, what's the role of liver transplantation in such a setting? Because most of this mortality is very high in this HRS, do you advise or advocate this liver transplantation at this the impending HRS?
Yes, sir. Impending HRS or the diagnosis of HRS. Matlab, after HRS, obviously the curative is only liver transplantation. If the duration of HRS is less than 6 weeks, without any kidney transplantation, directly liver transplantation will reverse this HRS. But after 6 weeks, it is combined liver plus kidney. So liver transplantation is not precluded, or the decision of that cannot be based on HRS. If the patient has liver failure and it is a candidate for liver transplant, it has to be taken up without irrespective of the HRS presence or absence.
But furthering sir's question, HRS itself is an independent criteria for liver
Yes, sir.
transplant.
Yes,
Basically,
Yes, right.
yes, sir.
Dheeraj is there. Dheeraj, anything to add? Dheeraj?
I'm here, sir. I'm here.
No, anything you want to add?
So, Dr. Kishore, I should really appreciate you for handling so many rapid fire questions from all the eminent people over here. And you are nicely brushed by all the recent knowledge and everything. It was a really good presentation. I don't have any doubts.
Now, Kishore, now
Sir.
the incidence of this metabolic disease syndrome is increasing. Now, because most of the cirrhosis are also this NASH related and NAFLD related cirrhosis, and can we expect a metabolic nephropathy in such patients, and the incidence of HRS is more in such a setting?
Basically, sir, metabolic nephropathy, and metabolic nephropathy, there is no such entity, sir. But any renal disease related to metabolic nephropathy or something is related to diabetes or hypertension only, sir. But there is no histological diagnosis in relation to nephrology with relation to metabolic nephropathy.
Because one condition is hyperuricemia and can lead to is part of metabolic syndrome as well as with this kidney
So that
problem.
is specific etiology, sir. Actually, it
Yes,
is
specific.
superficial nephritis, but not all patients with hyperuricemia will have kidney disease. So that is in fact a rarer condition. Whatever I have seen, only few cases only. That too, we require biopsy diagnosis of hyperuricemic nephropathy. Without that, we cannot diagnose. So that is a little
Because generally the hyperuricemia is not treated unless the patient is symptomatic. But what I feel is whatever the etiology, whatever the coexisting condition, hyperuricemia has to be treated even if they're asymptomatic. Because incipient this nephropathy can happen.
Yes,
That's what I feel. I don't know.
but recent studies in nephrology, generally we don't advocate treating the hyperuricemia, sir, unless there is gout, because there are recent studies which have shown no benefit in relation to renal dysfunction over the long term. Previously we used to treat, but now two studies are published in NEJM in the last year, I think. After that we have stopped. So if the creatinine is even more than 7, 8, 9, we don't treat unless the patient has gout or any specific complication related to hyperuricemia.
Dr. Kishore, one question from my side is that in the setting of this HRS, AKI or non-AKI, under which limited circumstances you will consider starting CRRT or hemodialysis? Like, so at what is that cutoff point where you will say now with medications like terlipressin, albumin, NORAD, I should also start the CRRT?
The role of CRRT, especially in patients with cirrhosis, is important because obviously compared to normal HD, CRRT is a lot better in these patients. Why? Because especially in IC bleed patients or the patients with raised ICT and also in cirrhosis, because here also we'll have the cerebral edema. Normal hemodialysis will rapidly decrease the factors in the blood or the electrolytes or the decrease in ammonia or all those things, which can worsen the patient. So if we have the availability of CRRT and if the hemodynamics are slightly borderline, it is better always to start CRRT, but cost is a very important factor here. And the patient basically CRRT is preferred for the slow removal of waste products in these patients to prevent the further worsening of cerebral edema in these patients, which is already present. So I would, in our setting, if the patient is severe shock on multiple inotropes, definitely CRRT is available. We need to take care. If the patient, if the BP is fine, I will do a SLED. So I won't do normal HD even if the BP is more than 90 or something. I generally use the SLED in these patients to remove it slowly.
So the clinical guidance would be based upon the creatinine value, some creatinine value, or some urine
No,
output value,
no,
or
no.
some uremic complications.
Requirement of dialysis is similar between patients without HRS and with HRS or any other AKI. It is hyperkalemia or severe acidosis or a specific cutoff of urea or creatinine, which we generally use in our hospital or pulmonary edema. That won't change, but the modality and the duration of dialysis changes in respect to IC bleed or in cirrhosis patient. That is the only
Agreed.
difference.
Dr. Ramesh probably wants to ask a question.
Yeah,
Yes,
thank you very much. And the hepatorenal syndrome type 1, type 2, you have mentioned, Dr. Kishore. Are they
Sir.
progressive? Once set in, are they progressive or there are temporary phenomenon like complications arising out of the factors?
No, HRS1, sir. In fact, it is highly, the mortality is very high. If you don't treat, the survival is only few weeks. So it is very important. If we don't intervene, it is progressive. It is progressive and it will lead to death of the patient.
So
And
it's
HRS2 is yes, sir. HRS2 is slightly milder type of disease. Over long time, it will progress. Basically, it won't stay at creatinine 1.5 to 2. It will also progress, but it is a slowly progressive disease when compared to HRS1, which progresses abruptly. And that is
so,
the
So
well,
thank you, Doctor.
Dr. Sudhir,
Yes, yes, sir.
since being a kidney liver center, most of the folks know as the liver kidney center, gastro liver kidney. It's time for you guys, gastroenterology, to be very serious and more dedicated to the hepatic problems, which are more statistically also, and you are also treating good number. I
Yeah,
appreciate
yes, sir.
people have an algorithm when you follow up a case of chronic liver disease, maybe going cirrhosis or blood hypertension, whatever it is, depending complications due course of time. It's time for you guys to have an algorithm where proper assessment and also cross consultation takes place to preempt and predict the ongoing complication, including the HRS1 and 2 and all those things.
Yeah.
I'm afraid one of you should be more dedicated to liver rather than having very casual approach, because a specialist is one who knows more and more about less and less. I leave it to you guys, your wise judgment.
That's really a good point, sir, because that's the main purpose of having these interactions and discussions. We'll follow that, I think. Yeah. So thank you, Dr. Kishore. It was a nice and exhaustive, very informative session. We had a good interaction, and then you clarified many of our doubts. Thank you.